You know that feeling, right? That sudden jolt, maybe when you're startled or even just excited. Your heart pounds.
Yeah, that's pure adrenaline. Or norepinephrine doing its thing. It's your body's built-in alert system kicking in.
Exactly. But sometimes, well, sometimes that system needs a bit of fine-tuning, doesn't it? A little adjustment.
It does. And that's where modern medicine often steps in. Today, we're going to dive into two really important groups of medications that help with that: antiadrenergic drugs and calcium channel blockers.
Right. And you've pulled together some fantastic sources for us. Pretty detailed stuff. Medical presentations, guides, the works. Our plan is to really unpack how these drugs work, like on a basic level.
Yeah, what they treat, how they affect the body. Some of it's quite surprising, actually.
Think of this as your fast track to understanding the real science behind how these meds tweak our internal responses.
We'll be drawing from those deep dives on the antiadrenergics, how they're classified, how they actually do what they do, their effects.
And then we'll compare them with calcium channel blockers, looking at specific drugs and what makes them unique.
It's a pretty fascinating look at how we can sort of regulate our own body chemistry for better health.
Okay, so let's start at the beginning. The body's own messaging system, these adrenergic receptors. Where does this signal even come from?
It starts with things called catecholamines. You've probably heard of the main ones, norepinephrine and epinephrine, which is adrenaline.
Right.
They're actually made from an amino acid, tyrosine. And your adrenal glands, they release them straight into your blood. Pow. Instant messengers.
And these messages need somewhere to go, right? The receptors.
Exactly. Adrenergic receptors are the receivers, two main families, alpha and beta. And then subtypes within those, like alpha-1, alpha-2, beta-1, beta-2, even beta-3.
And they're not just in one place.
Oh, no. They're all over. In smooth muscle, think your blood vessels, airways, bladder, gut, definitely in the heart. Even on nerve endings themselves, they're pretty widespread.
So what happens normally when these receptors get a signal, like alpha-1?
Good question. Alpha-1 stimulation generally makes smooth muscle contract. Squeeze. That's really key for keeping your blood vessels toned, maintaining blood pressure.
Okay. And beta receptors?
Beta stimulation tends to ramp things up in the heart, faster heart rate, stronger contractions. So understanding this normal function is like step one to understanding how the drugs block these actions.
Right. So if that's the normal response, the volume up, how do we turn it down? That brings us to the antiadrenergic drugs.
Precisely. Antiadrenergic drugs. Or you might hear adrenergic antagonists, sympatholytics, lots of names. But the core idea is simple. They block or antagonize the effects of adrenaline and norepinephrine at those alpha and beta receptors.
So like a dimmer switch for the fight or flight system.
That's a great way to put it. They damp down those sympathetic nervous system responses.
Okay, let's get into the nitty-gritty, the mechanisms. How does an alpha-1 blocker actually work? You mentioned alpha-1 causes contraction via calcium.
Right. So normally, alpha-1 activation turns on an enzyme, phospholipase C. Think of it like flicking a switch. That switch lets calcium flood into the muscle cell, and calcium makes it contract. Alpha-1 antagonists basically block that initial switch flicking. No switch, no calcium flood, the muscle stays relaxed.
And the result is vasodilations.
Right.
Wider blood vessels.
Exactly. Vasodilation, which lowers blood pressure. And it can also relax muscles in the bladder, which, helps with urination problems sometimes.
Okay, interesting. Now, alpha-2 antagonists sound a bit weird. You said blocking them increases the signal.
Yeah, it's a bit backward sounding at first. Alpha-2 receptors are mostly on the nerve endings, releasing norepinephrine. Their job is normally to act like a brake. They tell the nerve ending, okay, release less norepinephrine now.
A feedback loop.
Kind of, yeah. So if you block that brake with an alpha-2 antagonist, the nerve ending doesn't get the slowdown signal. It keeps pumping out more norepinephrine.
Which leads to more adrenergic stimulation overall.
Right. And that's important because it helps explain certain side effects you might see with drugs that block both alpha types, like reflex tachycardia, the heart speeding up because blood pressure dropped too fast.
Okay, that makes more sense now. What about the beta blockers? Probably the ones people have heard of most.
Definitely. So beta receptor stimulation normally boosts something called LAGMP inside the cell. CMP is like an internal go signal, contract harder, beat faster, that kind of thing.
Right.
Beta blockers physically get in the way. They compete with adrenaline and norepinephrine for those beta receptor spots. If the drug is sitting there, the adrenaline can't bind, so you don't get that boost in CAMP.
So it blocks the go signal.
Pretty much. It inhibits those effects. And what's interesting is the sources mentioned they don't do that much when you're just sitting calmly at rest.
Ah,
But when you're stressed or exercising and your natural catecholamines are high, that's when the beta blocker really makes a difference by capping that response.
so it prevents the system from going into overdrive.
Exactly. It
Angela.
keeps things more level.
Okay, so let's talk specific drugs. You mentioned different types. Alpha blockers first.
Sure. You have alpha-1 selective ones. Drugs like prazosin, doxazosin, terazosin, tamsulosin. Tamsulosin is really common for BPH, benign prostatic hyperplasia, because it targets those bladder muscles well.
Right, helps with urinary flow.
Then you have the non-selective ones blocking both alpha-1 and alpha-2. Phenoxybenzimine, phentolamine.
Yep.
Less common, used for specific things like certain tumors. And there are alpha-2 selective blockers like yohimbine, but it's more experimental, not really standard treatment.
Gotcha. And the beta blockers. Lots of categories there, too.
Yeah, several ways to slice it. You've got the beta-1 selective ones, often called cardioselective, because beta-1 receptors are mostly in the heart. Think atenolol, metoprolol, esmolol, nebivolol.
So they target the heart more specifically.
Generally, yes.
Yeah.
Then there are the non-selective ones, propranolol, nadolol, timolol. They block both beta-1 and beta-2 receptors, which are found elsewhere, like the lungs. Then a slightly different group, pindolol and acebutol, have what's called partial agonist activity. Bit complex, but they block mostly, but also give a tiny bit of stimulation.
Interesting.
And finally, you have the mixed blockers, carvedilol and labetalol. These block both alpha and beta receptors, so they give you vasodilation and the heart effects, a 2-for-1 deal.
Wow, okay. So the uses must be really broad then, given all these types. What are alpha blockers typically used for?
Hypertension is a big one. BPH, as we said, using drugs like prazosin or tamsulosin. Phenoxybenzimine is key for managing pheochromocytoma, that rare adrenal tumor pumping out adrenaline.
Right.
Phentolamine has been used for erectile dysfunction sometimes. And interestingly, prazosin is sometimes used off-label for PTSD, specifically to reduce nightmares.
Really? That's fascinating. And beta blockers. Seems like they're used for everything.
Almost. They're workhorses in cardiology, hypertension, angina, chest pain, atrial fibrillation, managing heart failure, helping people recover after a heart attack. Huge range there.
And outside the heart.
Oh, yeah. Migraine prevention. Essential tremor, that shaky hand condition. Anxiety, especially performance anxiety, like for public speaking.
The classic propranolol use.
Exactly. Also, glaucoma, timolol eye drops are common. Certain types of bleeding in the esophagus, and even helping manage symptoms of an overactive thyroid, hyperthyroidism. Very versatile.
Okay, something else you mentioned was how they get processed by the body, the pharmacokinetics, and this blood-brain barrier thing.
Right, that's a really important distinction, especially with beta blockers. It comes down to whether they like fat or water, lipid-soluble, or water-soluble.
Okay.
Lipid-soluble ones like propranolol and metoprolol can easily cross the blood-brain barrier, BBB, and get into your central nervous system.
And that means?
Potential for more CNS side effects. Things like weird dreams, maybe feeling a bit foggy or tired. It can be a real issue for some people. These drugs are usually broken down by the liver and eliminated in bile.
And the water-soluble ones?
Like atenolol or nadolol. They have a much harder time crossing the BBB. So generally, fewer of those CNS side effects, which can be a big advantage. These are typically cleared out by the kidneys in urine.
So choosing the right beta blocker might depend on whether those brain-related side effects are a concern.
Definitely. It's part of tailoring the therapy to the individual patient.
Okay, let's switch gears now. Calcium channel blockers, CCBs. You said they achieve similar goals but work differently.
Completely different mechanism, yeah. They don't mess with the adrenergic receptors at all. Instead, as the name suggests, they block calcium channels.
Calcium channels, like little gates for calcium ion.
Exactly. These gates control the flow of calcium into cells, and that flow is absolutely vital for muscle contraction, both smooth muscle, like in blood vessels, and the heart muscle itself. It's also key for electrical conduction in the heart.
So blocking these channels, what does that do physiologically?
Well, the big one is vasodilation. All CCCs relax smooth muscle in arteries and arterioles, making them wider.
Just like some of the antiadrenergics.
Right, similar end result, different path. This widening reduces peripheral resistance, the pushback against blood flow. That lowers blood pressure.
And helps the heart.
Absolutely. Lower pressure means the heart doesn't have to work as hard to pump blood out. Plus, CCBs often dilate the coronary arteries themselves, the ones feeding the heart muscle, improving its oxygen supply. So, less work, more oxygen, great for angina.
Makes sense. And you mentioned heart rate effects, too.
Yes, many of them do. They can slow down the heart's natural pacemaker, the SA node, and also slow down the electrical signal as it passes through the AV node. This makes them really useful for controlling fast heart rhythms, certain tachycardias or tachyarrhythmias.
Okay, are there different types of CCBs as well?
Broadly, yes. We can kind of split them based on where they work best. You have drugs like nifedipine and amlodipine. These are more selective for the calcium channels in blood vessels.
So their main job is vasodilation.
Pretty much. Lowering blood pressure is their strong suit. But an important point, especially with the older, short-acting nifedipine, they can sometimes cause reflex tachycardia. Like we talked about with the alpha blockers, the body overcompensating.
Exactly. Blood pressure drops, the nervous system signals the heart to speed up, and because these drugs don't directly slow the heart much, that tachycardia can happen. Also, these types generally aren't used for arrhythmias.
What about side effects for those?
Typical vasodilation stuff. Headache, feeling flushed, sometimes nausea. Ankle swelling or edema is quite common. Dizziness, too.
Okay, then what's the other group?
That would be verapamil and diltiazem. These are less selective. They block calcium channels effectively in blood vessels and in the heart muscle and the AV node.
So they do both jobs, vasodilation and slowing the heart.
Correct. So they lower blood pressure, but they also directly slow the heart rate and conduction. This means they don't usually cause reflex tachycardia, and they are effective for treating certain arrhythmias.
But there's a caution there. Yes, definitely. Because they slow AV node conduction, combining them with other drugs that do the same thing, like beta blockers or digoxin, can be risky. It could slow the heart down too much, potentially causing heart block. Careful monitoring is needed.
Good point. And you mentioned something about CCBs potentially worsening heart failure, negative inotropy.
Right. Inotropy refers to the force of muscle contraction. Calcium is essential for heart muscle squeeze. Since CCBs block calcium entry, they can slightly weaken that squeeze. That's the negative inotropic effect.
So they make the heart pump a bit less forcefully.
Correct. Now, for many people, reducing the heart's workload is good. But if someone already has significant heart failure where the pump is weak to begin with, reducing its force further could potentially make things worse. It's something doctors weigh carefully.
Okay, that's a really important consideration. Let's talk side effects and interactions more broadly across both classes. Any overlaps?
Sure, both antiadrenergics, especially beta blockers, and CCBs can cause bradycardia, which is a slow heart rate, and hypotension, low blood pressure. Dizziness often goes along with that. Fatigue can happen with beta blockers.
And differences?
Beta blockers can sometimes affect sexual function and occasionally cause diarrhea. That CNS stuff, the dreams or fogginess, is mostly with the lipid-soluble beta blockers. CCBs are more known for headache, flushing, the ankle swelling we mentioned, and often constipation, particularly with verapamil.
Got it. What about major drug interactions we should be aware of?
Well, we mentioned the CCB interaction with beta blockers or digoxin causing potential heart block. Another big one is combining alpha blockers with ED drugs like sildenafil, Viagra. Both cause vasodilation, so together they can cause a really dangerous drop in blood pressure.
Okay, good to know.
Also, taking beta blockers with certain diuretics, especially loop diuretics, can increase the risk of hypotension. And something common NSAIDs, like ibuprofen, can sometimes make beta blockers less effective at lowering blood pressure.
All right, worth keeping in mind. And finally, you touched on overdose, specifically with beta blockers. Sounds quite serious.
It can be, yes. An overdose is serious business. Symptoms usually show up within, say, 2 to 6 hours. The big things are severe bradycardia, really slow heart rate, and profound hypotension, low blood pressure.
Leading to shock.
It can lead to cardiogenic shock, where the heart just can't pump effectively enough. You can also see mental status changes, confusion, even coma or seizures. Sometimes bronchospasm, making breathing difficult, and low blood sugar, hypoglycemia.
And the treatment involves specific antidotes.
Yeah, it's about reversing those effects. Atropine might be used for the slow heart rate. Glucagon is actually a key antidote for beta blocker toxicity. It helps bypass the blocked receptors. Calcium salts can help support heart function. Vasopressors might be needed to raise blood pressure. 4-V-dextrose for the low blood sugar. Benzodiazepines if there are seizures. It's an intensive care situation.
Wow. It really underscores how potent these medications are.
Absolutely. They need to be used carefully and correctly.
Okay, so we've really covered a lot of ground here. We've taken this deep dive into antiadrenergic drugs and calcium channel blockers.
Yeah, looking at how they target these very specific systems, the whole adrenaline response, the calcium regulation to treat really common and serious conditions like high blood pressure, angina, arrhythmias.
It's fascinating how precisely they work.
It really is.
So thinking about all this, how these powerful medicines work by making these sort of subtle adjustments to signals and channels inside us, what does that make you think about our own physiology?
Well, it just highlights the incredible complexity, doesn't it? And the resilience, how finely tuned everything is. And it also shows you the level of precision that's needed in medicine to intervene effectively.
Yeah, intervening without upsetting the whole balance. It's a constant balancing act, trying to fix one thing without causing problems elsewhere. A powerful reminder of how intricate we are and how targeted modern therapies have become.